This is the story of your healthcare data. You are unique, so is your healthcare data. Ever wondered why you have to tell your health story to doctors and health practitioners over and over again? To date, giving you access to your data has been tricky, as health systems often speak different languages. Why can't everyone just be on the same page, right? Enter Sparked, Australia's fire accelerator. Putting your health journey front and centre, the Spark community is standardising the way your data is recorded and shared through the Australian adoption of the International Data and Exchange Standard, FHIR. Because your health data is exactly that, yours. Captured at the point of care, it follows you seamlessly, giving you and your healthcare providers a more complete picture of your health situation, with access to the right data, in the right format, at the right time. Now, what Bright Spark thought of that? Sparked. Better standards, better health, better outcomes.
Hello to all the bright sparks there in the chat attending the Sparked Symposium for 2025. My name is Peter Birch. I'm here clicking buttons and saying words, and next to me is the very important Kate Ebrell. Great to see you after the break, Kate. How's your morning been so far? I've seen you very active in the chat. We've seen you up on screen as well, but how's the day gone so far?
Wow, what a morning. I said this next session was going to be my favourite session of the day, but it's a pretty tough act to follow what we've heard from so far. So been an awesome conversation in the chat. So everyone, please keep commenting, keep chatting, keep asking questions, and excited about what's about to come next.
Yeah, absolutely. And look, and thank you just before we do jump into that, there are heaps of comments and suggestions that people can check out in their own time in the Menti on the side happening there too. So thank you for those. And we'll reflect on that probably a little bit in the last couple of minutes of the day, because we've still got plenty more to get through. But Kate, I'd love to hear from you on what we should expect for this next session.
Yeah, I'm so excited about this next session, because I think what we wanted to highlight, and I mentioned this earlier this morning, a lot of what we've done around standards and digital health over the very many years has been build it and they will come. And what we've been actively all working together here to do is let's build it together. And let's develop together, and let's actually make sure that what we're doing is actually fit for purpose for clinicians, for consumers, and that, we're not letting perfect be the enemy of good. We're actually doing this in an agile and iterative way. So we are, very pleased that some of our originals, our OGs who have been on the Spark journey with us from the very beginning have been invited to come along and showcase where they're at. Now, just like the jurisdictions, we unfortunately could not have all of our Bright Sparks and all of our OGs in the next session. This is only a sample. And, if you guys really enjoyed today, let us know, because then we'll try and keep doing a little bit more regularly to provide these opportunities to showcase and demonstrate what's going on. So we're really just going to have a sample of some of the work that our industry has been doing around how they're already looking to implement AU Core, AU Patient Summary, AU eRequesting. So all those terms that we've heard about all morning, we're actually going to see in action through some of these video demonstrations, and really pleased that we've got some of our industry and our clinical and consumer reps who've been on this journey with us to have a little bit of a chat around what they've been doing, why this is important, and where we want to go next. So back to you, Pete.
Yeah, look, it's a busy little backstage area, I've got to say, and so looking forward to the live conversations with those participants, and we do have a few videos to keep us on track to see things in action. Now, and actually, look, judging by the chat, look, Kate, I did promise we wouldn't discuss anything about trade wars, but looking at the discussion about chocolate frogs and the trade wars happening backstage right now is next level. Cutting a fine line there, Peter Birch. Wow. But look, I can see, look, there's obviously good connections and the vibe generally. I can't wait to share these all with you. So, Kate, I'm going to drop you off the screen while we start going through all of these discussions with these awesome participants. Okay. So the first up I'm going to bring up onto the screen, I should have brought you all up at the same time. I didn't get enough time in that little funky little intro. But joining me up on screen is Fabrina, Jess, and Phil. I'll get you each to introduce yourselves a little bit shortly. But for the general flow for this, for those in attendance, will be we'll have a bit of a discussion, frame up what we're going to see on the screen, and you can provide that context. Then we'll bring everyone back on screen and really test the limits of the platform to get everyone's perspective in real time. But firstly, Phil, did you want to help us frame things up a little bit more in terms of what this particular demonstration will be?
Perfect. Sounds good. Thanks for that, Peter. So we're really excited. One of the Oracle hospital sites has purchased the Oracle HIE, and as part of that has a partnership with some GPs in their catchment area to turf out. Turf's probably the wrong word to actually use now that I say that, but anyway, to share the patient load with the GP population if you're actually not all that urgent and you don't need to sit and wait for hours and hours in the emergency department. And the GPs that they have in that particular hospital that they partner with to do that kind of shared appointment arranging so that you can still get care happens to be on best practice. And so knowing that the best practice team was part of the founding membership of Sparked, along with Oracle Health, we thought, what a perfect time to show the power of the AU IPS and the FHIR protocols for use to populate out the Oracle HIE view. And that view, as you'll see in the video, is available to it's available to GPs in best practice, so the GPs can see hospital level data, the hospital sharing with them, and then over time, what we're expecting as we are, as that consortium and governance agrees to implement what we're also proving in this video is that we can then expose the GP level data to the hospital. So if I'm the ED clinician or a discharging clinician, I can see the plan of care. I can see the medication lists and some of those kinds of things. So it's super powerful. I think it's the first major case that I'm aware of really having that dynamic workflow between the GP and the hospital systems and really putting it at the point of use, whether you are the GP or the clinician in the hospital. Of course, my health record and all the other kinds of applications exist, but you'll see in this demo, a change is made in one system. It's immediately available and viewable through the other. Fabrina, Jess, glad to join you through the Fabrina side. Anything else you wanted to add there?
Lag. There we go.
Obviously just like, hopefully you guys can hear us, by the way. We had some technical issues, of course. It's just life-changing, this whole thing. Having data available at point of care and accessible by both the GP and the hospital, also while the patients transition to that healthcare kind of arena, is just it's something we've been working on for many, many years. And it's good to actually see it come to fruition. And working with the guys at Oracle has just been such a positive experience, and we're so excited to be able to show that this is actually happening now. It's real life, and it's about to actually make such a difference to so many people.
Yes, amazing. Look, I thank you for that context too, and I jumped the gun a little bit in terms of this flow. Sorry, Fabrina, I think there's a massive delay, and so you'll start talking while I'm. I do want to provide that demonstration in just a minute here, but I feel like it's important too. What we might do, we might backtrack a little bit because I was jumping straight into the demonstrations from the participants. So we've got that context from best practice here, but firstly, I wanted to actually bring on, because as Kate mentioned too, that we've got the OGs, the participants, all the different perspectives that come from the ecosystem and the Spark community. I've got with me Harry. G'day, Harry Isles, man. It's great to have you here on the screen. And there he is. Sorry, Chris, I was looking for you in my... It's such a party back there in the speaker lounge, so to speak, that I couldn't... Oh, you got the chocolate frogs! There you go.
Yeah, proof. I just want to prove I have some.
Thank you. I apologize for jumping the gun because we even chatted about it. I had a good plan. But before we dive in, we got a bit of a sneak peek on what we're to expect. But I wanted to actually go to you firstly, a bit more understand the why, because we can talk about what we're going to do and we can get so busy in the doing things and implementing bits and pieces. But perhaps, Harry, you might want to kick us off and provide some... I think a lot of people would know who you might be, but for those unfamiliar, provide some context on why all of this will be important.
Hello, everyone. Thanks for having me. Look, I suppose, yes, for a bit of background for those that have been fortunate enough not to have to tolerate me speaking before. My name's Harry Isles-Mann. I'm a health consumer leader. I'm a young person living with complex chronic illness and disability, recipient of 2 liver transplants as well. I've done a lot of work with states, territories and Commonwealth around digital health reform. Currently a co-lead for the Spark program and doing some work with Commonwealth government around representation of consumers in the digital health reform agenda. Look, for me, I think, honestly, I suppose there's a couple of sort of key points for me at a high level. And it really does sort of sit in a couple of distinct camps around improving equity in care, improving experiences of care, but then sort of specifically speaking to where I think for a lot of people the standards piece is really sort of going to come into its own is really the conversation around access, connection, ownership, and a sense of custodianship over one's own health information. For me, and it's thinking about, in anticipation of this, really trying to think about what's a good example of sort of the distance that we've actually covered, and even thinking about my own lifetime is actually going back to, originally when I was transitioning from one pediatric hospital to another. That circumstance was that I actually had one specialist that was a family friend, had to get in a fight with the specialist that was looking after me and threatened to take them to AHPRA because they were refusing to share my medical records. And that was 25 years ago to now, the point we're at now, which is this fervent support of and an understanding really that the notion of not sharing or making accessible or connecting up the way fundamental information about my care is actually shared with the people that are responsible for supporting me, but also to provide me with a sense of agency so that I can actually take myself out there into the world is a huge leap that we've made. And I think that's not a sort of, to me, that's not an insignificant thing to have made as a leap in this space. And I think to a certain extent, one of the things for me that sort of sits under all the technical conversation about the possibilities ahead that I think is probably the most important thing is that this has broken ground for a change in the way that we actually connect with and communicate with one another in this space. And to me, it's the culture piece that actually sits driving underneath this that may not always be visible and sometimes, gets a little bit caught up in the prickly stuff around the technical specifications. But it's really that cultural shift that I think is probably the most significant thing that excites me about the work in this space.
Amazing. No, look, thank you for that context. And Chris, I've been made aware you're familiar with this demonstration, the combination of Oracle Health and best practice that you've seen recently as well. Love to get any thoughts from you, and not just about that one specifically, but about generally the importance of this work and what you've seen so far.
Look, I think within Spark, I've been pigeonholed as the grumpy Dr. GP, the prototype grumpy Dr. GP. I think part of it is you can see, on the ground level, we you see that number, 40% of a consultation is administrative time. That means 15%. That means 6 minutes of every 15-minute appointment that I have a patient, I'm looking at my computer or running down and getting a fax or doing something like that. That means there's only 9 minutes for looking at my patient. It means workarounds. It means more after hours work. It doesn't even include the time for the staff actually who are running around, trying to get the data for me. That's what makes me grumpy. And that's why I think you see a lot of grumpiness amongst doctors. I think the other reason, I've been around in this area for a long time now, and I've been involved in, lots of working groups trying to, push forward the digital agenda. 20 years, in dingy dark rooms and spending a lot of time, a lot of intellectual effort, not ever seeing anything. I think what we've seen was sparked in an unbelievable amount of time. I mean, quite shocking, actually. Even with the foundational work of, AUCDI, which was really the core of the core type stuff, just basic data, was that straight away we saw this enthusiasm for vendors that we'd never seen before, which just leveraged it straight away, got to see it straight away, instead of going from where they've been in the past. And I think we have been in the past of inertia. They've just joined in and seen the promise and the possibilities of innovation, and really that leads back to the potential for, in fact, actually, number one, seeing stuff actually come out of the work that we all do, which is amazing, but also really having an effect on our day-to-day work, my day-to-day work. The average GP does not have any idea what interoperability is. They just see friction in terms of trying to get the data or sending the data. But now we have this chance and this really sort of very active and flexible chance to actually move forward. And I think it's so good to see some of the work that's been done so far by these companies who, we've spent a lot, let's be frank. Sorry, Jess and company, we've been spending a lot of time complaining about you for a long time, but we've seen some amazing work from you now. So thank you. So look, and we saw it back in, it was in Adelaide, I think, for the first time. I was kind of blown away when I saw what you did. So look, I hope you can show everybody else what you've been doing.
Amazing. Well, look, without further ado, let's take a look at what we're talking about with this particular demonstration that of Oracle Health and best practice combined. Here we go.
Best Practice Software and Oracle Health are excited to demonstrate a live version of the Australian Patient Summary. The Patient Summary demonstration uses Oracle's Health Information Exchange platform to share patient data in near real time between Best Practices Management System BP Premier and a Metropolitan Hospital's electronic medical record. Developed as part of the Sparks program with the CSIRO, the Australian Patient Summary uses the AU Core dataset and is aligned with the International Patient Summary Standard, or IPS. Oracle's Health Information Exchange is a revolutionary step toward data sharing in the future of healthcare and demonstrates Oracle Health and Best Practice Software's commitment to investment in the Spark program. Australia has many digital health services spread across local, state, and national regions. Our systems are divided by funding, governance, specialty, digital maturity, standards compliance, and more. This fragmentation can act as a barrier to continuity of care. Up-to-date patient information is not available in a convenient and timely manner between providers as patients move from one care context to another. Oracle's HIE is a centralized repository where providers can access comprehensive and up-to-date patient information regardless of the healthcare system where the data was generated, connecting multiple systems. Information that can be displayed from the HIE includes laboratory results, diagnostic reports, medication histories, documents, and other patient information. Data displayed in the patient summary shows the most recent source and can be drilled down on to view underlying details, such as the last update or the investigation reports. The Oracle HIE employs standardized data and security formats and messaging protocols, including HL7 FHIR resources to ensure the confidentiality, integrity, and availability of patient data. The Oracle HIE allows technology vendors like Best Practice Software to support GPs with access to clinical information from hospitals, specialists, and other providers. For example, say a patient books a regular post-discharge follow-up with their GP. Without needing to wait for a discharge summary, the GP can open the AU patient summary from the PMS and filter to the most recent information, see the latest lab results, check for any new documents, and check for any new medications. Oracle's HIE employs the AU patient summary. Itself is based on the International Patient Summary, a globally recognized standard with a commitment to adoption by G7 nations. Using global FHIR standards for the IPS makes life easier for vendors to join the Spark community and work toward true real-time interoperability. In the future, hospital networks, specialist practices, allied health, aged care, and many other healthcare organizations could benefit from Oracle's Health Information Exchange data sharing platform. The patient summary presented through Oracle's HIE can be localized based on regional requirements and clinical context. For example, the Indigenous Health Check history found under Documents is an adaptation of the IPS for Australia. The web portal version of the AU patient summary will be available for providers who are outside of the practice or hospital. Back at the desk, Single sign-on can be used to seamlessly access the patient summary from your PMS or EMR system. Other enhancements coming in the near future include the write-back of key clinical information from the Oracle HIE to the PMS, supporting meaningful reuse of data, change notifications so clinicians can have real-time alerts of clinical episodes, and exports of some components to CDA or PDF where required. Oracle's Health Information Exchange solves the problem of fragmented patient data across multiple systems. By enabling access to a patient's clinical history at any point of care, Oracle's HIE enhances care coordination, supports informed decision-making, reduces duplicate testing, minimizes medical errors, and enhances patient safety and satisfaction.
How cool was that? So as Kate's pointed out too, this is just a sample that we're going to run through today, and there'll be more available and you'll be able to watch these in your own time. We've got the luxury and the privilege of being able to speak with some of those innovators and organizations that are making this kind of thing possible. So, in the spirit of continuing on and looking at in this show and tell, I'm enjoying this. We're going to bring on Monica as the next participant. G'day, Monica Trujillo. How are you?
Hey, Peter, and hey, everyone. How cool was that? Like, so cool.
Pretty good. It's great to see these types of things in action because we get caught up often talking about what needs to happen. Let's get the rubber on the road. And I'd love to hear from your side. Particularly, from your clinical context and the background that you bring, perhaps just what Telstra Health is doing in this space and the importance of it from a clinical side of things.
Well, I'm still getting over how cool that is. So, and it just blows the mind of what we can do. And so, if you think about Telstra Health and where we are, we're connected to pretty much every part of the healthcare ecosystem. So, we're in primary care, aged care, community-based care, rural, remote, acute care, virtual care, revenue cycle management, and look, there's so much more as well. So, it's been a journey for ourselves to tie in all our solutions, and honestly, for us, interop just means really cutting through that clutter to really focus on what's important, which is patients, their carers, the communities, and as an Australian-based company, this is really our communities, and so it's really about supporting us to make sure we get the best outcome for our communities. But it hasn't been an easy journey, and it's a tough challenge. And I think we were commenting before as well that the technology is there for a majority for us, and seeing it in practice is so cool as well. But it's really around if you look at the levels of the interop. So we've been working on that foundational aspects and the structural one, and all the bit about the semantic interop as well. But it's really where I see. I was going to, pardon the pun, when you see the spark or the shining or where it shines. And look, it's in that governance and policy interop, and that's where sparked shines. I actually didn't prepare that, but that it just came out like that as well. That's where it shines in terms of technology being available. Working together is the only way that we could really make a difference. And going back to Chris's comments, and I was fortunate to see some of the jurisdiction session as well. It's really just all in, right? All in. And then going back to Kate's comment in another session, really, it's around, and as a dog lover, it's about, standards are like puppies. It is really, I love that comment, because we really need to, as we all commit, we really need to keep on working together. And that's what the brilliance of this is. So so for us, you'll see some examples that we've focused, trying to go back to the comment of the different areas that we work. You'll see examples that we worked with, between jurisdiction and pathology, in aged care and transfer of information. And last year, if you remember, I think we were in a podcast together when we launched our Smart API Plus for Helix, and which is a sort of cloud-based primary care product, so that we could, remember the open up on the laneways as well, to make sure we could do that. So we've been working at it a technical, from a product perspective, but this community approach and seeing what we can do and showing and showcasing is so important. So, you know, we of course we have a video as well, and there's a prepared video. I'm sure you're going to play, Peter, but that was because what we want to do is in all the areas, and you'll see that in the showcase, in all the areas, start to bring in that. So, and you know, with a partnership with Smile, and you know, we've put the that is available as well in some of the we've put a fire server available that free of charge to support the connectathons as well, so that we can see what we can do. But really, that's where we are at. That's what we're working on. We're working on different areas so that we can bring that to life in all the different areas that we sort of touch.
Cool. Well, I can't wait to see. Shall we give it a play and look to see?
Go for it.
Yeah, let's do it.
Thank you for the opportunity to share the impact that the Sparked Accelerator has had on our solutions at Telstra Health. Telstra Health solutions support a broad range of healthcare settings, from primary and aged care to pharmacy, hospitals, virtual care, and population health. But as anyone in healthcare knows, no system exists in isolation. Every system holds a piece of the patient story, and it's only by sharing those pieces that we can deliver truly connected care. Traditionally, every new implementation involves costly bespoke integrations. And you've probably heard the old saying, if you've seen one HL7 message, you've seen one HL7 message. And that's why Telstra Health sees FHIR as a real opportunity. But it's only an opportunity if we adopt it in collaboration with other solutions in the ecosystem. Without standardization, we risk repeating the same fragmentation that we saw with HL7 version 2. And this is where the Sparked FHIR Accelerator comes in. Not just a set of technical standards, but a national community of government, providers, clinicians, peak bodies, and vendors like ourselves working together to define a template for building interoperable solutions. And we think this is important because ultimately, the value of Sparked is about delivering what matters most: better care for patients. It allows people to tell their story once and have it follow them across their multiple care journeys. It allows them to receive the best care, which is supported by both timely and complete clinical information. Let's take a look at how Telstra Health has been adopting the Sparked FHIR Accelerator in its solutions. Our first example of information exchange is the common GP visit that results in a blood test referral. Today, this process is often paper-based or relies on custom integrations tied to a single pathology provider. Now, as a patient, I have been known to leave the clinic with a printed form. I head home, I put the form down, and after a few weeks, sometimes months, I've forgotten what I've done with that form. And typically, I'll have to call the GP practice and say, can you send me a replacement form, please? The AU eRequesting standard starts putting in the key building blocks and putting those in place to improve on that experience. It defines how GPs can send electronic pathology requests directly to a nominated lab, a process known as an assigned order, and allowing them to retrieve the request electronically, automatically loading it into their system, which both reduces administrative effort and eliminates errors often due to mistakes made during manual re-entry. It's the first small step in a longer journey, but it has big implications for both clinical safety and efficiency. The diagram you can see on the screen describes the flow. The Smart Connect widget, which is part of Telstra Health's Smart Connected Care Suite, extends Medical Director Clinical, enabling a FHIR service request to be generated for the order. This is then sent to our Health Information Exchange and made available to downstream laboratories. I'd just like to run through a quick demo of how we've incorporated electronic ordering using the AU eRequesting standard in Medical Director Clinical. In this demonstration, I'm using the non-production samples database. So picture a consultation with a patient named Angelina Clements. As the appointment progresses, her doctor decides it would be appropriate to order a blood test for further investigation. So she launches the pathology request portal and requests a couple of blood tests as she would normally do. For our demonstration, let's select an iron study, which we can search for manually and add that to the list, and also a thyroid hormone test. Now, on clicking print, the doctor is presented with a new dialog which allows her to create the digital order. We can see that all the information is pre-filled, such as the patient's demographics and the tests we've just selected. And the doctor has the option of making modifications to that, such as adding a new test, selecting the lab that the request is to be sent to, or maybe just adding a comment. In our case, no further changes are required and she can electronically sign and submit the order. And really, that's all that there is to it. The order is added to the clinical record with a minimal change to the GP's existing workflow. The request is sent to Telstra Health's HIE using the AU eRequesting standard, and it's now available for the pathology lab to retrieve and ingest it into their lab information system. This work is still in progress. We're currently engaging with both public and private pathology providers to deliver a solution that fully aligns with the AU eRequesting standard for assigned orders. And we've recently begun the discovery work for diagnostic imaging. We are looking forward to collaborating with the community on priorities like subscription notifications, unassigned orders that can be retrieved by any participating lab, and ultimately, we'd love to get to the place where we have consumer held orders that are accessible via QR code on their phone, giving patients both choice and convenience while still ensuring the safe and efficient processing of the order. In the aged care space, we've just started the journey with patient summaries. When a resident requires urgent medical attention, it would be nice if clinicians that are outside of the residential aged care facility were able to assess the urgency of their care based on their most recent clinical information. This information, along with their historical record, can be used to triage their case, potentially by telehealth, to determine if a visit to the emergency department is required. We are looking at exposing this information as an AU patient summary that external clinical teams can retrieve into their existing systems to support residents and aged care providers. Every day, clinical teams capture information about patients, residents, or participants in wellbeing programs. Yet often, the same information is recorded in slightly different ways across different systems, making it harder to compare or interpret results consistently. This lack of standardization creates barriers to delivering coordinated care and limits the usefulness of data in improving health outcomes. Smart on Fire apps offer a powerful interoperable solution. They are built on open healthcare standards and run seamlessly within the context of a clinical system, enabling consistent data capture, up-to-date clinical decision support, and easier adoption of evolving best practices. Our Helix practice management system natively supports Smart on Fire apps through its integration with Smile CDR, a leading Fire platform from our partner Smile Digital Health. We've adopted the AU core standard for Helix integration to ensure it meets the requirements of nationally developed assessment forms and their corresponding clinical decision support tools. We're in the discovery phase to determine how we include a similar capability inside our medical director clinical and communicare products, which will increase the availability of nationally developed assessment tools to health providers that use our products. We're looking forward to continuing our collaboration with the Spark community as we make good on our mission to realize a connected and improved digital health experience for all. Thank you.
Love seeing the real examples and seeing the comments in the chat of people resonating with the problems that are being solved. As we continue on here at the Spark Symposium, we're looking at demonstrations of the getting it done part, the real world application, and beyond the talk, the important talk that needs to happen. Now it's the action side. We'll continue on with one of the those that are doing that. I'm going to bring on Mike from Magentus. G'day, Mike. How you going?
Good. How are you?
Good. That was my delay tactic to make sure I'm bringing on the right individuals. But look, I know you're super active in the Spark community. I'd love to hear what Magentis is working on, particularly around eRequesting. Is that right?
That's correct, Pete. Yeah, no, I can give you a bit of an overview of what we've been up to in the space. We've been working with FHIR for many years, but now we're working with the national eRequesting standard for pathology and radiology requests. And the good news is we're out there in production on this right across our partners who I'm representing today, Sonic, Helios and Australian Clinical Labs for pathology in the private sector, that is. So it's a bit more of a private use case. And we're now using the same pattern, the same standard for radiology or diagnostic imaging. And we're out there in the wild, so to speak, with Sonic Radiology, and we've got a few others coming in the pipeline.
Yeah, amazing. Well, shall we play the video to see a bit of a run through of what this thing looks like? Any context you wanted to add to it?
Good idea. Thanks. Oh, no, let's go.
Let's let it run. Let's go.
For having us. My name's Mike Strachan. I'm joined with Akansha and Andy. We're from Magentis. We're going to do a demonstration of the Magentis eRequest. We are going to demonstrate today what we've done in pathology and radiology using the same AU eRequesting standard that's been developed through Spark. It's important to understand that this is a workflow pattern that supports a service request and fulfillment by the placer and the filler, and Andy will touch on that throughout the presentation. It's key to really importantly understand that it's very different from a HL7 messaging model where a message is delivered and then the job is done. We're doing a back and forth interaction between Magentis and our diagnostic partners. For today's demonstration, we're going to demonstrate Sonic Radiology's workflow, Helios pathology workflow, and ACL pathology workflow. Sonic also do have pathology as well. However, just due to time constraints, that's what we'll demonstration today. I'm going to hand over to Akansha and Andy. Thanks, everyone.
Right, this is a patient, John, and I'll create a pathology request for him. This request is for Australian Clinical Labs. It's gone for the lab to pick it up. I'll create another request in parallel for another patient. All the clinical information, pregnancy information, that's already pre-populated in here, and that will go along with the request. This request is for Jane for Helios pathologies. Now we can see these requests are here for Australian Clinical Labs and Turnovich. And once the lab starts accepting it, making it in progress or completing it, the statuses will be reflected in here.
Traditionally, HL7 version 2 based messaging has not provided transparency of fulfillment by the filler. In our approach, the clinician can see when a request has been placed, when it is picked up by a filler, when the patient arrives for collection, and when the report has been completed. This transparency ensures greater focus on the clinical collaboration between the clinician and the pathology service, providing greater transparency, trust, and patient safety. You might notice some delay in the statuses being updated in the user interface. This is normal because the demonstration is a little artificial as the status changes happen over time and are not packed together in a real-time sequence as you're seeing in this demonstration.
You can see once the request is completed, you can start seeing here. The one for ACL is completed now. And similarly, when the lab has the request and it is in progress, that would also start getting reflected in here for this lab here. See, this one for Dora, which is now in progress. All right, I will start with creating a radiology request for this particular patient. I'll select a lab, which is a digital lab.
We distinguish digital labs from traditional address book labs. Digital labs have a capability to receive digital orders while address book labs may not.
Sends an SMS to the patient. You can also print and keep a copy. Otherwise, you can start seeing the results in this section for this patient. So right now it's requested, but then once the lab accepts it, it will start changing statuses, and you can start seeing all the statuses right here from in progress to completed afterwards. You'll start seeing all the statuses here as soon as it's in progress. Now you can see that this request is in progress, which means that the patient has turned up at the radiology center for getting their test done. And then this information is shared with clinician. Now, once the test is completed, you can start seeing the status as completed for the request. Now, as you can see, that the status is completed, and that is reflected everywhere for this particular patient. That's a radiology order all the way through.
Thanks for the great presentation, Akanksha and Andy. Just want to close our demonstration with a discussion about where we're headed in the future and some of the future opportunities that we see using the AU eRequesting standard that are developed through Sparked. For certain things such as extended clinical history, looking at AU patient summary and potentially attaching that to the request, which would be really exciting potentially in the future. Round tripping the report, the request, the report going back to the request and round tripping that back onto the FHIR repository. Certainly looking at decision support into the future as well. But right now we are focused on working with Sonic, Helios and ACL on what we call digital request sharing or alternate lab claiming, which is the ability for a consumer's digital data to follow them to whichever diagnostic pathology service that they use. We're estimating that launch will be sometime in June. We're very excited about this because we think this is a step towards supporting the current patient-consumer choice setting that patients' digital data can follow them in the ecosystem. Thank you all for your attention.
Oh, I started talking and I wasn't on the screen. Amazing. No, it's great to be able to see those real world examples, and I can see comments and questions in the chat. Please do keep those coming through, because we will be bringing everyone on stage to try and address as many as we can. For those quite specific questions that come through in the chat, if those in attendance can multitask and put any replies that are easy to reply to, that will also result in happy attendees and questions answered and ripe conversation to continue. As we roll on through, I'm going to bring up our next participant, Andrew. Andrew Aho from InterSystems. Great to see you again, sir.
You too. Thanks for having me.
Amazing. Well, look, I would love to hear a little bit more about what you're doing around the smart launch side, what this implementation look like, and the stuff that InterSystems is doing.
Sure. Well, look, apologies in advance. I don't have a video with those beautiful rolling credits like Michael and the team at Magentis had, but we do have a 2-minute example coming up of a few things really, but it's a back-end fire server, which you can't see it all, obviously. A lot of what we do around standards and interoperability is behind the scenes. But we did use, Nicole Sun on our team used the CSIRO EHR launch capability, some open source tech to be able to show a cardiovascular disease calculator, one of those national standardized calculators that was talked about earlier, inside of an EHR. Really being able to invoke this very easily, simply, reliably, and bring it into the hands of the clinician so that they're not spending that 40% of the time really stuck in front of the computer trying to figure out how the system works, but really easy to use kind of applications and standardized forms that you might have used elsewhere. I think Smart on Fire is a pretty interesting approach, something that we didn't do a lot of locally here so long ago. But as we know, EMRs, EHRs, clinical systems have a reputation for being tricky and difficult to change. And there's obviously not just technology reasons for that. But when you do make changes, there's a lot of training and other things that go into it. And a story that kind of changed my mind on Smart on Fire in particular, I was reminded of this actually. Brett Sutton talked about the social determinants of health earlier, and sometimes it can be poverty that actually plays the biggest impact on how healthy an individual or a population might be. But one of our overseas examples of use of Smart on Fire was to connect two HIEs together, and they were able to deploy inside of the clinical viewer and the EHR systems the ability for the clinician to see if a patient, if you could tell that they were maybe struggling, if they were suffering food insecurity, or maybe housing, you could automatically refer them to a local service where they could get some help and support from that. Now, there's lots of things you can do with Smart on Fire, but the thing I loved about that was they set out to do that with zero training. And so being able to implement that sort of capability with Smart on Fire with zero training, I think is kind of the promise of what we might have here. So really, really good stuff. I don't know how exactly much time this calculator work that Nicole and the team did recently, but we did have just yesterday another InterSystems partner, a company called Tech Intro. They've got a Smart on Fire app around patient summary. They decided to see how hard it was to connect it up to the back-end fire server, and I'm told they did that in just a couple of hours yesterday. So I think the proof is really there, and some really exciting stuff.
Amazing. Oh, well, let's check out the video and see it in action.
Let's do it.
Hi, everyone. I'm going to show the Smart on Fire EHR launch with Iris for Health. Let's start. This is the Smart EHR Launcher, which is an open source application I have deployed on my local PC. At the back end, it has been connected to Iris for Health file server on the EC2 instance. All this information about the patient and the practitioner here, they are AU core file resources on the file server. In this demo, we want to focus on these two launch buttons. These two launch buttons will trigger the Smart on File process to allow the applications to be launched and to access the information on the file server. Let's have a look at the first one. Once I click the button, it triggers the OAuth 2 process. In this process, it will go through the Smart on File orchestration, allows the application to access some informations from the file server. We can see the patient information which required for this application has been brought across. There are only a few informations that are not on the file server, that's why they are not here. I just manually enter them. Finish the forms. So once the result has been calculated, we can save the result back into the file server. Once the result is saved back into file server, this result can be accessed by the EHR itself. This is the first example. Let's take a look at the second example. I want to show the second example, just want to show you how easy different applications can be launched through the similar process for the same EHR application. Here we launch the OAuth 2 process for the Smart on File again, and we allow this application to access the practitioner and the patient information. The process itself is very similar. The applications are very different. So this is the end of the demonstration. Hopefully give you some idea how we can use Smart on File to launch smart applications to access some information from the file server with a very secure way. So this is the overview of how we can use Smart on File to enable secure and standard-based application integration. Thank you.
I nearly said you're welcome, but it was recorded video. But amazing. It's great to see those examples in different settings too, and different use cases. And it's great to see, in the chat too, as Kate mentioned, that this is just a small sample of the activity that's happening, and great to see across the ecosystem that there's hopefully a lot more of this to come too. But it's just giving you a taste. And I figure before we bring everyone back on screen to have a bit more of a discussion and put some context and perhaps answer some questions that might be in the chat. Another familiar face within the Spark community. I'll bring on Kim for a moment too, because you and I can have a bit of a chat too. Great to see you here. Thanks so much for joining.
It's a pleasure. I hope I'm not sounding too echoey.
That mic quality is the highest that we've had in participation at this event. So you and I could host this thing now. So this is amazing.
There you go. Let's
go. However, I did want to have a chat with you, and actually, there's a good chunk of the participants who are attending live at the Spark Symposium who may not have attended, and this might be their first experience and interaction with Spark. Firstly, if you could set the scene, tell us a little bit more about you and what you do, and why all this work is important to you as a pediatrician, as your lower third set.
Yeah, so look, I'm not an OG. I'm a fairly new person to the community, but I'm a developmental pediatrician, and I'm coming to you from my office today. And I see kids every day who have complex needs, and really I work at that intersection of children in general. Are they not just at the intersection of everything that health is about? It's not just hospital care, it's not just private suites that they come to see, but it's also education and justice and just everything. You can't get away from the social determinants of health, and I'm really glad that Brett brought that up. But that is my playground every day. I have kids that come in here. I'm going to get
it's apt that you speak about the children and the light shines.
That's right. That's right.
So
that's right. Everybody take note. That's a sign.
It is.
So I guess there's two reasons that I'm in this community. Look, driven out of frustration and burnout, and I was looking for something that would help me with the enormous amount of paperwork that I do. And I echo Chris Moy's, comments about just how much time I spend navigating a healthcare system on behalf of my patients. It just drives me nuts. And that's just to get something done, and then something's expected of me, which is often a lot of paperwork and reports for the NDIS. So, I can't work more than 4 days a week because I need at least a day and a half to do all of my admin. So right now I'm so busy that I only work 3 days a week because I need a day and a half. So it's not a business model that works. Anyway, I'm here because, driven by that frustration, I'm an early adopter of the ambient scribes and have very enthusiastically, grabbed that technology, embraced it, was very nervous about it, but it's really solved a pain point for me. It was pretty awful at the beginning, and I'm talking in AI terms, 2023, so July 2023, trained on orthopedic surgeons doesn't equal pediatric practice, just telling you. So wanting it to work and needing it to work, because I wanted to stay in practice, I formed a bit of a partnership with them and have continued to advise them just to make sure that it thinks like me, but not for me. And that's a really key distinction. And I've remained in that space because I just enjoy crafting a tool that will actually help me to enter the child's story into the medical record, and that's really what I do. So I'm here for that. And yeah.
Well, I was going to say, just thinking about all of the discussions, as Brett spoke about and Andrew highlighted, that it's not just about episodic care, and there's the whole, I guess, lifespan of an individual as well. That's important that we get this data right too. So I feel like that's a critical point in what you're saying as well. Yeah.
Yeah. Look, I have a background in public health, and so I've always had that broader perspective. And I think when you're working with children, you can't get away from the social determinants of healthcare. So it really does inform my approach to using technology, and my frustration with it. But yes, I mean, I sit here often at the beginning of someone's health journey, and that journey is hopefully many, many decades long. And so I want to make sure that what I'm putting into the record has integrity over a long time. And what I see in the SPART community is this way to, well, let me rephrase. I am obviously an AI enthusiast, okay, and I know that there's lots of risk, but the possibility is amazing, but none of it will happen unless that information is interoperable. Otherwise, we just build the same things that we always have. And so I guess that's why I'm here. I'm like, I need the data to be useful.
Yeah, such good framing for us to then come back to all of those that provided a bit of a demonstration, because I know that resonates with many who are in attendance through the chat. I can see, but I can see some nodding backstage too, where there's agreeance there. So give me a moment, and we'll bring everyone on stage, and let's dive into the detail together. I think I got everyone in that, but you shouldn't have drawn attention to it, Peter Birch. It could have been seamless, and that was it. There's a lot of clicking in that short space of time. Look, thank you everyone for providing those demonstrations and the context too. And this is probably the biggest. This isn't a panel. This is a party that we've got here. So let's make the most of that opportunity. And it is legit. The Brady Bunch, when people make that joke about Brady Bunch Zoom calls, it's literally, we could do something clever if we had more time. But I can see there's quite a few questions that are, in the chat that kind of came up through people's demonstrations specifically. So they're probably not the best ones for us to dive into. As a panel here, but perhaps I would like to go around, because it's been, I didn't get to hear fully from Fabrina. If I was to just come back around and think about each of the sessions, I know each presentation provided a good snapshot of what's happening today and then what's to come. But, from your perspective too, what are the important priorities right now, given the work that has been done, and what can we expect next, particularly through your context as well, in terms of the work that you do on a day-to-day?
Look, I'm a GP, and I am also a clinical advisor to best practice. And I am involved in a few working groups, and I work with some clinical work groups, and we always come back the same conversation, the same problem, is how do we build a solution for this healthcare problem that we have, and how can we make it interoperable? How can we allow healthcare workers using different systems, different technologies, to have that ability to adapt these innovations that we're working on. And so the interoperability and the Spark community obviously is very important for us to move forward and work together towards solutions that can be used and not having to reinvent the wheel all the time.
No, thank you. It sounds like we've got a bit of a lag issue. Oh, there we go. We've got the last out of the bandwidth out of the best practice officers or wherever they're joining from. But no, I'm just being cheeky. But no, it's great to be able to have that context too from Barina as well. If we were to continue on that, Phil, from your perspective as well, looking at the what's next, or what does this open up? Because sometimes I find, when you demonstrate a particular capability, I look at the, in the chat too, people are like, oh, that means you can do this, and that means you can do this. All of a sudden it becomes like this insurmountable kind of, it's like, well, have we even progressed? But I guess I'd love to get your thoughts on, like, well, where's the priority at right now, given that we've just started to do what you've demonstrated to us?
Yeah, no, I love it. And I love all the demonstrations here. And I think, I think maybe if I take it a little bit different than what you're asking, Peter, is thinking through each one of us. So each of these vendors have done very different implementations of using the SparkFire, formatting or ways of modeling healthcare data. And each of us would claim, if we had to do compliance tomorrow, each of us would claim compliance tomorrow, right? But you can see if you're joining that they're very different use cases. And so I think, one of the next things here, besides taking these things to scale, right, is getting some agreement on some of the integration patterns and thinking through how do we use the Sparked formats, the tools that we have created to model Australian healthcare data, but actually make that transition of care happen, right? And so that may be focusing on eRequesting of path and radiology, as we saw from the Magentis team. It might be sharing an IPS in a FHIR format, and between more than just best practice and Oracle, but also finding the coalition of the willing, that it's willing to do some of the governance to say, okay, let's extend this on to other GP systems, other specialty systems, residential aged care. There's so many different parts of our health system that are desperate, even ambulance. Sorry, when I had a conversation with some of the ambulance folks, and they're desperate to see some of this information. They have valid clinical use cases of why they need to understand what you're allergic to or what your alerts are, and some of those kinds of concepts, and sharing that information. But, as John was talking about earlier, from a TASI perspective, we have to move away from that kind of inwardly looking system perspective, and we need to look at that outwardly view. And that does require some coordination from some of the teams, probably outside of Sparked, right? And some of our government colleagues to help align some of those incentives. So I'm excited. I think hopefully I've answered your question, Peter, of, there's plenty of ways to grow. Each of us could grow any of our networks or our use cases so much bigger. But I think what's critical next is some agreement on what some of those integration pathways might look like, because then we can all go in the same direction, right? And we can get to that network benefit that helps all of us, and it's more than a sum of one or two or three examples, right?
Yeah. 100%, and that answer was better than the question I asked. And just a forewarning to all the panelists, I just say words to you, and you say whatever you like, to be honest, because you're all super smart individuals.
Sorry, I shouldn't have done that.
No, I'm joking. It's a good thing. Do that again, please, because what's important is that this is the stuff that's front of mind. So it's I'm legitimately super happy with that because they pull on important points. Because and actually I might go to Monica too for a typical question without notice, but I guess, pulling on Phil's point that, all of this is great, but as soon as it becomes it needs to happen within this walled garden, it kind of, you lose the any benefit from it whatsoever. So, I'd love to hear your thoughts on, like, once we can demonstrate it with, those participating vendors and parties that are there, like, how important is it that this kind of capability extends out to the whole technology ecosystem for digital health?
I think what's great of today as well is showing that, and I don't know who said it, maybe it was Peter, maybe it was Phil, I don't remember, but it was like, before it was like, actually, I think it was Chris, said the vendors were always held to it's the vendors doing, we can't see the vendors and the vendors, I can't remember who it was. It was, anyway. But I think what you can see is that we're way on this fast path to the technology's there, is what I'm saying. Technology's there. We all are putting some use cases together. I couldn't agree more with Philip's comment on scalability. That is such an important comment, because remember your comment of pilotitis, and now it's changed to use case itis maybe, that we get to. We need to make sure that that is a sustainable, scalable process, and that's what sometimes takes the time. But once it's there, can we please not go back to reinvent the wheel or do other bespoke solutions that come back with other things that are not there? Like industry, and we're here to work together to accelerate. Like I read a comment the other day that said, the technology is only as good as your data is. And so if we want to make sure that we're moving forward, tech is there, our data models are there through the Spark community, and it's about making sure that all the time invested in that that's that avenue to move forward, as opposed to going, oh no, maybe we should try this other, and maybe we should try this other thing here, as opposed to saying, okay, these are the 4 things that we saw, 5 things. Let's then get behind it. And when I say get behind it, you combat government, industry, all sorts of partners, and then just make this at a scale level. And can I just then at the same time, I think there's a little bit of education in terms of what is what, because when I talk about, and have these conversations with people, and I'll be interested to see what other panelists say about, how we work in interoperability, how this is going to make such a difference. I still get the comment of, well, isn't that what my health record was meant to do? And it's very different, because my health record is there as a repository of information. It's there to support information, but it's not meant to replace what we're doing here at all. And I think there's some level of maybe it's confusion, or I don't know what it is. When I get asked the question, it's like, we sometimes, we're so embedded into this world of we know what we're talking about. It's like, let's bring it back to helping our community understand why we're doing it and why it's so different, or why every single bit of it makes a difference. So my health record has a huge place, and we can go and find information, but the interop and in dynamic workflows and in workflows is such a different way to add to the safety of the patient journey through this all as well, right? So anyway, random thoughts put together, Peter.
Love the random thoughts, and because I want to go to Harry for a moment, because on that point too, it can be in the busyness of being software vendors or technologists and in the digital space. Often, it can be quite the notion statement to say, well, let's engage. Let's make sure patients are engaged and all of that too. Would love to hear your thoughts on the like what all this is going to mean in the reality, in the real world. How close or far are we from this kind of stuff having a real impact in communities that need it the most? And I guess in looking at some of the demonstrations too, like stuff that comes to mind and reflections from this particular session from you, Harry Osman.
So it's like you're reading my mind. I'm glad you used the word reality. I was reflecting sort of in the lead up to this, and just generally after having a bit of time off recently as well, just on sort of where this piece sits within something bigger, because I think that's something key that we need to keep in mind, is that the be all and end all isn't the data piece. It's a part of a much bigger sort of sphere of things happening. And I think the reality thing is a really interesting sort of notion to unpack. I really like sort of the notion that reality isn't reality, narrative is reality. In actual fact, I mean, it's, without getting on the sort of existential tangent of what's happening in the world, but the ability to sort of define what we see in front of us is not really reliant on what's actually in front of us, it's the story that we attach to it. And I think to the same extent, We also have a really interesting opportunity in front of us with the work that we're doing in standards and connectivity, and just sort of broadly in the digital space as well, around what constitutes value. But I think something that's really important to keep in mind is that value in this instance isn't necessarily what value means. Value is actually what's meaningful to people more broadly. I think one of the really interesting opportunities that we have here, and something that I'm starting to see being unpacked, and I think to a certain extent why the cultural and the community piece is such a huge driver of the change that we're seeing, is really this idea that value and notions of meaning hold something beyond just the financial status or a cost benefit or a cost saving of the work that we're doing. You know, to me, a really good example that comes to mind is you could go, yeah, you could take a less mature view and say, look, it's easier for someone, to come with their own devices. I mean, like for a provider, you could say it's easier for patient to come to me to do my thing in, the space that I have set up to do it. That's all fine. That works. When the balance sheet or when the math that you're doing behind the scenes is, your own house of affairs, then that works out as a benefit. But when you actually look at the impost that poses to a patient potentially, and you reverse the benefit and say, okay, well, if you could go and see an elderly patient in their own home, that could also mean that elderly patient might be able to say yes to looking after their grandkids that day. And you start creating this sort of on-flow of costs more broadly. And I think that to me is one of the key sort of things that I'm seeing as an opportunity through the work that we're doing here, is not to get too far ahead, but to think about, if we do this well here and we lock down the data piece, standards interoperability and the ability to share and connect, if we do this really well, it actually builds a solid foundation for us to start considering notions of value and meaning in health more broadly, and the way that starts to plug into all the other different parts of the system. And I think to me, what's so significant, and Chris, to reflect on your reflections around, this being a momentous sort of point where all of these people that traditionally haven't worked together or worked the best together in the past have now come to the table. To me, it's a recognition that, this is not a pursuit of binary fragmented bottom lines. It's an understanding that cost saved and meaning and impact created here is actually going to impact something somewhere else. And it's okay if we don't see the benefit from doing what we do here, if it means that we'll actually shift the dial somewhere else that lifts everyone. I think to me, that's what I see as a probably not sort of the most surface level reflection about what's the immediate impact, but in a sort of thematic and community building sense, that to me is one of the things that really excites me.
Chris, I see a bit of nodding of heads going on, and frantic activity in the chat too. Would love your perspective on, not frantic, that's the wrong word, hive of activity happening in the chat there.
Can I say, I just realised today was a bit annoying. I'll explain why. I've got to say, I realised that all that hard work we've done in those rooms, getting all this foundational work done, all we've got out of that is actually friendships and chocolate, right? These guys get all to do all the sexy stuff.
No.
All these other people get to do all this sexy stuff, and they're just creating stuff, which I think is actually quite. I mean, I wrote in there that like my health record was always just a backstop because of lack of interoperability, and we can use that as another database to do amazing things, but it was built as a backstop because we could never move forward in interoperability. Now we can, which is unbelievable. And it's an exciting point that we're at. Now, I think Philip made a really good point. We Monica's, we just got to be careful about, not doing too much reinventing. And we're going to have constraints about things like, data finding and privacy and consent, all the stuff that, was talked about earlier today. But it is extremely exciting that we can move forward now for the first time, because getting the foundations right, just that work about, which seems sort of kind of almost a bit tedious at start, is really has borne this fruit already. Now the next bit will be which way we move forward. I asked the question earlier about, how do we decide which way we go forward now? We've had priorities, which are the patient record and care planning and those sort of things. But I think the next interesting thing will be actually the what's going to drive us as we move forward. But I think that will be the next big question, I think, whether it's going to be by sectorial things, like, for example, it might be the immunologists are going to drive allergies because we can really push that side of things further on, or or the pediatricians like Kim can move it in that direction. I think we're gonna have to make decisions about that. But it is so exciting to see what's happened today, because I've been grizzly not just because of the fact that I spend too much time doing admin, but it's because I have been in those dark rooms back 20 years ago, and we got nothing out of it, and it was and we got nothing out of it, and really now we're starting to see something out of it, and it's only 18 months, which is an amazing thing.
Yeah, well, just building on that too. Great reflections, by the way, Chris. You scared me for a minute, but we're good. We're good. We're allowed. Building on that concept and seeing innovative things being built. Now we're talking about standards, right? And typically a conversation about, well, let's implement some more standards. Often the mind might go to, well, this inhibits innovation. But maybe if I go to Mike and also if Andrew has any additional comments after, but perhaps Mike. From your perspective, well, from what it seems like to me is that, usually standards people might think as, well, this is inhibiting innovation. But I guess in these examples, if anything, it's enabling innovation. What's your thought around this dichotomy of standards versus innovation, and whether it we can innovate in spite of those standards, or we can innovate because of those? Or let's discuss.
Thanks, Pete. I'll try and reframe the question. No,
yeah, you go for it.
No, look, I think there is a common misconception that standards can maybe constrain innovation. I'd probably take an opposite view to that. I think you've seen all the amazing presentations today on the call using standards, and if you focus on the fact that maybe historical we've done lots of bespoke things that aren't reusable. The fact that we can build things in this community and keep it open, APIs, and then others can pick it up and use it in other parts of the ecosystem. I mean, we're excited about the fact that Phil and the team at BP have done the AU patient summary so that we can start leveraging that elsewhere. So I think the innovation that we're all doing together, we're a village in Sparked. And I think it's a bit of a hub for innovating. And I think obviously you can innovate without standards, but I think standards really does give us a lot of reuse that we can repurpose across the ecosystem, so that we're not in our own little corner trying to make a connection, in this part of the ecosystem. We need to take that and make that so that it's available right across every part, whether it's public or private. So I'd probably say I'm a fan of standards, and I think they're really the foundation for innovation.
Andrew, any other thoughts?
Yeah, I'd agree with Mike. I think you can innovate with standards. And obviously this is a village of people who like friendships, chocolate and wine. I think Kate added into the thing there. But for me, I mean, this innovation's been going on for years and years without standards. And as Mike said, it only happens in little pockets. It might happen in a bunch of areas. Over the last decade, the standards have been developed in other places other than Australia. In the last 18 months, we've been catching up. I think someone said earlier we're a little late to the party. Daniel McCabe might have said that. But look, we are here at the party, and there's chocolates and wine and friendship. And so this is the time when we can actually take that forward. I think Peter O'Halloran said, have everything aligned at once is kind of rare. That's what we're looking at here. I don't want to oversell it, but I think the other thing we need to consider is that there's a lot more that goes into making this successful than just the standards and the community. The technology, I think everyone's kind of agreed. There's been lots of it there, most of it available now. So what do we have to do next? How do we make sure that the innovations continue? How do we make sure that different parts of the sector are motivated? How do we make sure that clinicians understand the benefits and that they help to educate others and they adopt it? What's the government's role? In America, I know they had it was about 6 or 7 years, I think, where they talked about incentives and then they talked about the stick, what comes next, and they have actually implemented some of the fines. I'm not sure if they're actually chasing down the money yet or not, but I don't know how that's going to work in Australia is the point. but there needs to be a conversation of when and how. And I think that'll help people realise, hey, look, I've got to invest in this. And what's the timing for doing so? What are the things that are going to help me do that versus the things that are going to motivate me for negative reasons that are going to make me do that too?
Yeah, 100%. Phil, I know you've got a bit of thoughts on this topic too, yeah?
Yeah, I had one quick thought, and it kind of follows on with Andrew's thoughts. Looking at what we've seen in other countries, when we agree on a set of standards and agree on an integration pathway. So, an example of that could be Smart on Fire, right? Andrew showed that today, and Monica talked about that with Telstra Health, and I have some clients implementing Smart on Fire apps in Australia this moment. As we look through each of those, it creates a whole different kind of business ecosystem and a business case. If you are a niche vendor, if you have a great idea, I think most of us recognize, or at least the bigger systems recognize, we can't be everything to everyone in every situation. And the business case, if you have that great spark of an idea, probably doesn't stack up if you have to do a different design for every different vendor or every different instance of that vendor in Australia or around the world. And so, I think one of the things that I've really seen, which has been great to see, is that, the concepts of saying you have to handle in the US, it's, being able to do an HIE and CCDA format, maybe not Fire, and Smart on Fire has created this floor that every other great idea is technically possible because they know they have the standard that they can work against. And so that's what I'd love to see here. I'm not saying it has to be those exact same standards. It doesn't have to say the same, incentive alignment, et cetera. But that's the power that we don't even expect what those next great ideas will be, or the business that comes out of, serving a very particular niche specialty. But that all becomes a possible business case for someone to make, a reasonable business off of if they know they can access almost every system in an appropriate way with appropriate consent, and they don't have to keep redesigning.
Yeah, 100%. But I can see Mike as well. Did you have some additional thoughts on that one?
Just to build on what Phil was saying, look, just to round out sort of standards and innovation conversation, the work that we've done in the requesting space, I think Telstra are building on the same standard, right? So that's enabling SA pathology to be able to leverage from a consumer choice. I think there was a question in the chat from Lucas. Public pathology being able to access as well, consumers be able to access. We're looking at that now. I think there's heaps of innovation that sits on the top of this stuff that we're doing at a platform level across all of our organisations. The more that can be shared in an open style, the more we can lift everyone up in industry and that sort of broader ecosystem.
Yeah. Hey, Kim, I'm sitting here thinking, and you've probably got some more thoughts to build on that, but I guess in addition to the discussion that we're having here, I'm also thinking about all of this great work that's happening here, and we build the innovative tools and all of that. But in the end, they've got to these solutions, these technologies need to get into the clinics or the offices or the computers of the clinicians that are going to use them. And we're very lucky to have a good amount of clinicians here on this this session here now, and have drunk the Kool-Aid someone mentioned before and all that kind of stuff. And even if it's not like just recognizing the issue, but as we know too, there's a lot of clinicians that at a clinician level don't know or care, to be honest, about interoperability or about standards. Fire, the thing kind of just needs to work. How do we get, what's that going to look like when we because we know that implementation and adoption of technology is super critical for clinicians too. How do we kind of get that buy-in from clinicians on the importance of some of these tools that have been built around standards, and or would we even need to do much work to get the buy-in because the thing's just going to work, so they'll just love it and use it? What are your thoughts?
I could talk about this for hours, and I'm sure Mike might just be shaking in his boots right now. Long time Genie subscriber, now Magentis. Look, innovation obviously is the space that I'm in at the moment. Because I'm impatient for the tools that I use to work so that I can focus on my, on the work that I actually do, which is talking to patients. So once I've installed a practice management software, it does all the things generally that I want it to do. I'll put up with some things that aren't quite how I'd like them because it's good enough. And actually, it's not the main game. It's like, it does the job. I'm okay with that. So if I then want to use something that's new, a new feature or a new tool, it has to work with me, because if it doesn't matter how wonderful it is. If it breaks my workflow, I will just like flick it off. So that's one thing that, I've seen that on the inside of a Scribe company as well. I look at all the user feedback. They all love the Scribe until it suddenly doesn't do what they expect it to do. So not what it's programmed to do, like provide a diagnostic formulation in the form of a haiku. We are not programming that, people. We want the diagnostic formulation or the patient, the clinicians' thoughts to be in a structure that makes sense. So, but they'll get rid of it and they'll go to the competition. So there are, I think, as a practicing clinician who is also paying for the privilege to use these tools, right? We get pretty irritated when they don't work exactly the way we want. But perhaps because of our training, we've never really thought too hard until recently that we could have some sort of voice in the way that the product can be developed. So I never got to choose Epic or Cerner or whichever one was, at my hospital. I just put up with it. And if I work for myself, but if, I was working for someone else, they might have XYZ practice management software. I might not choose that, but I've got to work with it. So it's a complicated question to ask. I think it just has to work with the person's workflow. And we need to be really convinced that it's going to help us if there's a new feature. I hope that helps.
Certainly does. And such a great point around the, it's a challenging one then from a vendor's perspective to get, there's so many moving parts, and I guess if a solution's not meeting all the requirements, sometimes it can be a fickle kind of crowd. Like you've got one chance sometimes with clinicians, depending on the scenario, of course. I'd love to throw to Jess and Fabrina at Best Practice. I'm conscious that there is a 7-second delay, which we can edit out in the recording, but for those attending live, it'll be worth the couple of seconds that we wait for it to register on their end, and then I'll be quiet and let them talk and provide any perspectives they may have.
Yeah, Pete, thanks for that. Look, the Sparked program's been such an amazing initiative for our business, and I'd like to provide some insights for a number of reasons. I think we've talked a lot about interoperability and connecting systems and things like that, but the Sparked program and the FHIR standards have actually helped us internally. So actually helped us on our journey to cloud and actually connecting our own internal systems, which I don't think's been discussed today. We've kind of talked about a lot of connecting outside ecosystems, but the Spark standards have actually helped us on our journey to cloud. So we've got our BP mobile product fully built on AU Core. We've got our current on-premise solution, and we've got our future cloud product, all using FHIR standards and talking to each other. We've also obviously got our partner ecosystem. I know Mike touched on that previously, but being able to have all of our partners speaking the same language, be interoperable, and deliver fantastic solutions to our customers has just been absolutely amazing. And seeing standards being consistently used is saving time for software vendors. We have people approach us all the time. They've got a fantastic idea, a great initiative that they'd like to roll out to the healthcare ecosystem, but they're having to obviously customize the integration with us and other vendors. They're having to invest a lot of time and money. All of a sudden, they can come to a vendor with a fantastic idea, look to leverage FHIR and standards, and actually roll that solution out to the wider healthcare community. Standards are not actually stopping innovation, they're enabling it, and they're enabling us to do that amazing work internally. Externally, it's saving us time and it's adding so much value. And seeing what was showcased today is proof of that. So there's some really great stuff happening. We're just so excited.
And I just wanted to add on to Jess's point, as a clinician, I think Kim spoke about it before, it is difficult for us to keep up to date and on track with all of the latest innovations. And, signing up to different products can be quite cumbersome and can take away time from our patients. So I find with BP being able to integrate all of these different technologies, GPs just all we have to do is have our best practice session open, and as we saw in the demonstration with the Oracle, you just have to click on a link and the information is already there. You don't have to log into a different system or log in with two-factor authentication. It's there, it's seamless, and it just works.
Great summary there. Thank you for Brina and Jess. Look, we've got about 15 minutes left, but and that feels like plenty of time, but with so many participants with great perspectives, I would like to give each of you a final opportunity for final thoughts and reflections. Look, I was going to ask some more questions, which were kind of reflective of stuff coming through in the chat and things that come to mind too. I'm thinking about how, whilst we've seen this progress and the stars aligning as we're talking about, but what else do we need in order for the vendor community and government to work together, and where are we hitting kind of stop gaps? I guess I might leave it to you, given everyone's different perspectives on what it is we should be focusing on right now as an ecosystem to really continue this progress. It has been a while since I have heard from Monica, so I'm going to put you at the top of the queue and then we'll work on through, and I'll throw to each of you. So we'd love to hear some a couple of minutes for final thoughts, and we can go from there.
I think as we build towards the future, and when AI is all over the place, and it's embraced in some aspects by going back to the clinical community, because I think you've heard from across the area, everyone's looking for something that makes their life easier, so that Kim can actually add another day of clinical practice as opposed to take another day as well. So as we build that, we have to go back to basics and make sure that standards are what really is the ticket to play in that playing field, right? So that's what it is. So if we continue on this path, and we all have different priorities. For us, we're focusing on aged care, such an underserviced area. We need to focus on that. We have really focused on community-based care, rural, the benefits of what it can bring, and let's keep in mind we don't want to increase that digital divide as well. So we're all working on different priorities. I think making sure that we continue the community-based approach, the connectathons, the community, and the work that Spark is doing is giving us the ticket to play in this playing field, because I think we all have different things that we can bring in and contribute. We all know that we're competitive in some aspect, we're all competitors in something, but look at us, we're all working on solving this problem. So, we've demonstrated that we can do it. Standards are the ticket to play. We need to continue to do that. If we're going to build, the thing that scares me is the AI built on stuff that is not standards. Oh my gosh, that is a scary world as well. So so that's my thoughts. Heath.
Thank you, Monica. Chris, would love to hear from you.
Look, I think the things I'd say is where we need to go is I think we need to keep that really great balance. We've got this unusual community. I've joked about it being a cult because other people have called us a cult, but it's been this unusual group where we haven't have stuff imposed on us. We've actually taken ownership of this, and we've actually had fun and worked together in this and actually learned. I think the bridge between the clinicians and the software IT technical people, we've actually talked to each other. Now we understand each other a lot better, and we even like each other. So it's a great place that we're in, and I think we need to get that right balance instead of having things imposed on us, because once it gets imposed on us, it's their problem. If governments jump in too early, it's going to be their problem, not ours, and they'll have to solve the problem. I think the next sort of journey we're going to be on is the direction in terms of what's going to drive priorities, and also being able to sell it. I think that's the thing, and understanding what everybody else each person kind of needs. I think, for example, different sectors. I talked about pediatrics or one group. They're going to need it because they want to improve the data stuff that's actually usable for them. I think, for businesses, private business is going to be saving time. I've talked about numbers. I mean, you save half the admin time on a $100 consult. That's $20 back on the consult, right? That's a lot of money on every consult. I think from the point of view of governments, it's efficiency, it's patient safety, better care. And I think it's for consumers, it's actually far greater engagement and autonomy and patient control of their data, I think, really, because they actually understand things, they can get a hold of it for the first time. I think My Health Record has been the beginning of that, but that's, I think we're moving forward with this. And then I think for the technical people and the vendors, it's really this great chance to actually innovate, after a long period of, let's not call stagnation. We've been in our little hidey holes, sort of not feeling that we needed to stick on our own IP. I think you've got a chance now to innovate, which is, I think, really exciting as well. And all for the benefit of patients and the community. And we, maybe it'd be nice to actually just remember this. There's a little bit of service in there, that we're all part of a greater thing for the community and patients. And I think that's a wonderful thing as well.
Hey, look, just to come to Kim as well, off the back of what because Chris used that example of, the day of admin work, not to add on another element of the discussion, but, back to your point around AI, and I think this is going to get fleshed out more in some of the sessions this afternoon too, but we're spending so much time on creating standards could we not just AI the thing? I'm being a bit facetious in my comment for discussion purposes, but perhaps we'll put a flag in that one too, because I want to stay focused on you in particular, and just like where you see those priorities at right now, because ultimately, if that means that you could reduce that day and a half or whatever it was of admin time down to something less and have better outcomes, then that's got to be a good thing. And maybe standards and the work that Fire's doing will play a part in that. Spark is doing.
Yes.
Any other final thoughts?
Sorry,
I went on a ramble.
Look, I guess I prepared a little bit of something, and so that I could be concise is not one of my strong points. But I guess I just wanted to. The thing that I didn't say earlier on is that I am in this space and remain in this space because I think the child's voice, the child is a patient, and is a beautiful use case to what somebody else was saying before about needing a use case. They're the cleanest, generally, data, repository. You've got at least one benevolent, an adult with benevolent intent curating that data from the start. And I know that Harry has had the good fortune of a mum who understood the healthcare system from the inside out, thank goodness. But, children are who we're building this future for. And I find it's an observation anyway that, 20% of our population is under 18, and yet I don't hear them raised in these sorts of forums that often. So that's one of the other reasons that I'm here. And yeah, look, it's really important, I suppose, to know that whatever data I'm surfacing to inform my decisions, and those that I enter back in that will inform decisions well beyond my, encounter with that patient, they've got integrity, they will continue on. And I think, the thing that's missed a bit, even in today's symposium, is that the patient voice isn't there. And I think we underestimate just how literate they are in health and also digital, and what they will expect of us. So they expect us to have, and why wouldn't they, an interoperable system. I have kids here as young as 10 or 11, they've gone and had their blood test and they're like, that wasn't fun. And you don't have the blood test result? Like what? I'm like, it wasn't downloaded, and then I have to ring, and then it has to be faxed. And they're just like, what? I can order, I can Google some sneakers or something, and they can be in my postbox tomorrow. It's like, how is this? That disconnect is what will drive us to change. And we have a head start right now. And I guess that's what I like about Sparked. It's this rare opportunity, as someone said earlier, for us to get ahead of the curve, to ensure that the standards, which I think of as more of a line on a sporting field, and that we apply clinical governance to the way we play with that information is all set up, ready to go, because it should be and it will be very much more demanded of us. So, yeah, I want to keep practicing, but I want systems that will support me to keep practicing. Yeah. Anyway, I hope that's
great
helpful.
reflections. Thank you. Yeah, absolutely.
Yeah.
Harry, that probably then ties on to you as well. Any other reflections and final thoughts from you on this one?
I think one of the, and I'm not going to pretend I've thought on this long and hard. This is very in the moment, so if it's an awful reflection, let me know.
We've got a minute and a half.
Look, I think really, really critically that notion of literacy, and one of the things that I really want to try and impress upon people is actually just remove the digital bit from it. Everyone has a fundamental literacy and understanding of what's valuable to them and what means something to them. And I think one of the things we need to be really careful that we don't do is to go, all of this rests on a digital literacy bucket, when in actual reality, what we should be striving for is to try and create something that conveys or aligns with notions of value and meaning to people, because those will be things that they can pick up regardless of whatever level of health or digital literacy that they possess. So for me, I think that's one of the really critical parts and you can't achieve that unless you actually engage with people and make them a part of that process, so that we can sort of collectively produce some shared understanding of what constitutes value and meaning to people.
Love that. Thank you. Yep. Andrew, the floor is yours for any pre-prepared final statement.
Look, I just took a couple notes while everyone was talking. I mean, it's fantastic. I guess a range of different ideas and perspectives and experience here. Bottom line for me is that we all need healthcare, whether it's for us, for our families. I mean, this is something that I do. I contribute to digital health. My family's mostly medical, and I chose to go on the technology side. So I feel like I'm helping in my way, and they definitely help in theirs. But it's just not good enough that doctors. My brother's a GP, and he's given me the 40% statistic as well. It's just not good enough in this day and age. So Sparked and everything we're doing here is really our chance to make that change and that difference. Simon talked earlier about record portability. That's fantastic. That's what we're aiming for. But that's just the beginning, because the clean, reliable data means that Monica doesn't need to be so scared when we start using AI with it, right? So that's a really powerful thing that I'm looking forward to, which can unlock more proactive healthcare and wellness care, not just sick care. I think that's a really that's where the future will be, and we have to have this foundation in order to have that safely. And I did mention before, and I think a couple of others picked it up, but the government carrots and sticks, that's certainly a conversation. But where my thought and energy would be right now is this has been an excellent showcase of what's possible with 18 months of conversation, collaboration that's really only come together in the last couple of months. Some of those examples, and some of them I know Mike's work has been going on for a bit longer, but that's the bit that we really need to harness and get more of those stories out, showing people what's possible, showing them that there's better ways to work, and it's not that hard if we all collaborate and we talk to each other. So that'd be my suggestion. Let's keep doing more of that.
Yeah. Perfect. No, look, keen to hear from Mike too. And Andrew's right. We've seen some great momentum in what's, in perspective, a relatively short space of time in some parts. And would love to hear your thoughts on how we keep that momentum going, and any final thoughts.
Yeah, I think what Andrew said, I agree. I think we've made some great strides in this sort of short period through this community, but now the real challenge is how we take this more broadly right across the ecosystem. And probably my reflection would be not to wait for the carrots and sticks that Andrew was talking about. I think we do need some policy settings and some certainty for all of industry, if I put my industry hat on. But I think let's not make this a big waterfall exercise. Let's get on and start implementing now. Let's find the use cases and do it. Don't wait would be my sort of parting reflection to all of us in the community. Look what we've done in such a short period of time, but I feel like now we need to sort of be very strategic about targeting sort of use cases that will give maximum benefit for the lowest amount of effort and get on and do it, and not wait for regulation or anything like that. So that would be my parting reflection.
Great, excellent. Phil, you always have something wise to say in these moments. So
Thanks, Pete. I'm going to say I'm pulling a Dr. Kim, that I wrote a few things down on this. So I think to our government and our kind of coordinating bodies, I have some key messages of you need to keep investing in Sparked. We've just started in modeling a number of health data. It's the core that covers, the GPs and the hospitals and the specialists, the true core. But it misses whole areas of social determinants of health and care plans and goals and patient-specific views and other kinds of things that we need to model. So we need to keep investing in Spark. We need to define that method and that modeling so that we can start using those in so many different ways. I think we also need help in coordinating those actual transfer of workflows, and I'll say the aligning of incentives, whether it's carrots, sticks, whether it's whatever it is along the way. We need some help there, right? Because you can already see that a number of us are doing lots of great things, but we're all going in different directions. And if we want to get that network effect, we need some help in that. What is top priority? And let's all get aligned to get to that top priority. If you're a vendor on the line and you haven't started your FHIR journey, you need to come and join us. It's that simple, right? I totally admit, you just heard me, that I don't know exactly how you have to implement it, but you need to come join us. You need to be part of the discussion. If you're a dev and you have a great idea, or a clinician with a great idea, you need to be thinking very quickly, how do you use FHIR to access the data that you're looking for? Every one of us on this panel will quickly be pivoting, and probably plenty of other vendors will be pivoting to say, it needs to be via some sort of FHIR, whether it's Smart on FHIR or some other use cases. We're all going to say, that is the way that you get to a major client base that crosses many of our different platforms, and you access the data in a standard way rather than a bespoke way. And for the clinicians, I say have some hope, but also prod your vendors. Ask them what strategy they have. Where are they going? The vendors, you are the customer for us, right? And that's who we'll respond to, and that's how we make our own internal business cases, is that our client base is ready to invest in that. And there may be some elements that you will need to invest or plan for as part of your strategies too. And I fully admit I probably have missed some of our key components. I should have taken a screenshot of the Menti earlier, but hopefully I've covered many of the people who have joined. There's a reason to be part of this and to continue being a part of this.
Yeah. Such great summary there, Phil. I feel like it is important that we get a final reflection and thought on the best practice side, and I'll pause for Brina and Jess to open up their mic there. There'll be a bit of a delay, but then I'll let you talk, and then we'll wrap the session up.
Yeah, look, I couldn't agree more with Phil and the rest of the guys. We've got to keep going. We've got so much momentum. Government guys, we need you to keep focusing on this. We've shown that we can collaborate and work together. I think everyone's willing to keep giving it a crack. It would be good to obviously look at some guidelines or some mandates and some regulation, but I don't think we should be relying on that. I think we've just got to keep moving forward, be allowed to keep innovating, support, grow, learn, have the right people at the table, and show just how much value we can bring through the development of these standards.
Love it. I'm going to leave it there, but thank you so much for all of the participants who took part in this one today. It was a bumper session, and for those in the chat too that helped us keep things on track. So everybody on this screen, thank you so much for joining today. Did I get everyone? I did. There we go. Hey, we're going to drop into a quick break before we jump into the, I'm going to say afternoon session for us, but the rest of the world, if you're not from Australia, is waking up in some parts. And we've got so much more to cover here at the Sparked Symposium. We're going to be looking at the International Digital Health Standards leaders. So come back in about 10 minutes. We'll run a quick Menti while well, survey, that's what they're called, a survey while we do that. And this was the last one that we had up there, and it would be related to the session that we just had. Or actually, it's more just general. Oh, here we go. Yes. What should Sparked focus on next? So it is a bit of an open word, anything goes type response space. I'll leave this open during the break for a couple of minutes, and then we'll take a quick look at this probably at the end of the session. But do get a drink, have a quick break, and we will see you in about 10 minutes. Thank you.